Hello, friends. I'll be giving a brief overview on this MDR infections with emphasis on carbapenem-resistant infections and the role of polymyxin. So this talk will focus a bit on polymyxin. So this talk I gave it as a part of a training program for a group of African doctors in critical care at Kochi on 8th of March. So there were doctors who came from countries like Nigeria, Ghana, Ivory Coast, so on and so forth. So I had to deliberate on this particular topic. So when you look at antimicrobial, so we all understand, most of listeners are all experts in understanding that in ICU we deal with a lot of resistant infections. So when you look at the global sort of a prevalence of AMR means antimicrobial resistance, so it seems to be coming at fourth leading cause of death. So after cancers, I think cancer at this point of time seems to be leading, followed by diabetes, followed by diarrheal disease, road traffic, and AMR is sitting at around 700,000 deaths per year. So in 2050, it is estimated there will be 10 million deaths due to antimicrobial resistance. And there has been a progressive increase in the resistance ever since this has been identified as a global menace. And there are 10 million deaths happening every year. And it is expected that the GDP will be affected up to 100 trillion US dollars with expenditure on tackling this drug resistance. So that is the sort of a global burden that we have with antimicrobial resistance. So when you look at deaths attributable to AMR every year by 2050, so Asia, it is purported to be the highest, 4.73 million is what has been projected. And next comes Africa. Since this talk I'm giving to Africa, so Africa, it is touted to come at 4.15 million by 2050. This is the number of deaths that are going to happen with the antimicrobial resistance. And then Latin America is followed by 392 deaths, North America 317, and Europe 3. So this is the sort of a global projections that countries or the continents would be facing due to antimicrobial resistance. So this is the harsh reality. And unfortunate thing is the developing countries, the emerging countries, the Asian and African countries seem to be at the forefront. So all the more reason, more sort of regulatory steps have to be taken to curtail this emerging resistance. And India, as we know, is the hotbed for antimicrobial resistance. So NDM, so which is a dreaded species, which are typically carbapenemase resistant enterobacteriaceous species, and the NDMs are resistant to everything. So they were first identified in 2006, and then it spread to China in 2008, then went to Europe in 2009, and 2010 it was seen in US. So this was the sort of, so which means any resistance that we deal with have a global footprint. So they start somewhere and they do spread across the globe. So it's not the due diligence of a country, but it is a collective efforts from across which need to be put in place. And if you look at this slide, which is pretty saddening, so the carbapenem usage is very exponentially increasing. And if you see more so, it is high in a country like us, India, Pakistan, Egypt. So which is not a good thing at all, because if you see in USA, it is much lesser. So it is these developing and emerging countries which seem to be taking the burden of these resistance, and the over usage of these sort of antibiotics are happening in these countries. And if you look even in India, the antibiotic consumption has exponentially increased. So the gray one is the 2000, and if you see the blue one is 2010. So you see there is a sequential and exponential increase in the consumption of sort of antibiotics. And if you look precisely at the carbapenem resistance in blood culture, so there are two studies, Gandra et al. At 2016 and ICMR, our own data. They put this is the resistance patterns for carbapenem, and if you see it's highest in Acinetobacter. So 70.9% of Acinetobacter isolates are carbapenem resistant, and that is ICMR data, and followed by Kleb pneumonia. I'm sure all the listeners know that the bugs that we seem to be challenged with in ICU are predominantly Acinetobacter and Klebsiella, and they have very high resistance to carbapenems at this point of time. This is in 2016. Now, I'm sure this percentage is much higher than what it has been. So one thing for all the listeners, we need to bear in mind the type of organisms which pose a threat with antimicrobial resistance have been recognized by WHO and have been put in as an acronym as ESKAPE organisms. So these are the six dreaded pathogens that seems to be creating sort of a resistance burden in the community. These are called ESKAPE. So E and S are gram-positive organisms, which is Enterococcus species, which is Enterococcus faecalis or Faecium, and S is Staphylococcus. So these are gram-positive, and K stands for Klebsiella. So and A is Acinetobacter, P is Pseudomonas, E is Enterobacter species, and double E, another E is E. coli. So these are gram-negative. So these are the bugs which we sort of seem to be having a problem within ICU, in any ICUs, and these are the ones which we are trying to tackle, and the resistance patterns in these also are increasing. And what are the challenges? Why do we have the problem with these bugs? The problem is because of the ability to spread within the ecosystem. Because if you see this very nice figure, so these bugs spread very easily. So this spreads between the patients, from one patient to another, from doctor to the patient, doctor to the bedbound patient, and these are the visitors. So it tends to spread very easily amongst these caregivers within the given ecosystem. And there are less drugs which are effective against these escape organisms when they develop resistance. And the turnaround time to ascertain the resistant patterns also with conventional blood cultures are much longer. That's why we tend to resort to using point of care or PCR techniques is something that we adopt to get quick answers so that we act upon it in an emergent way. And it is shown the problem with these bugs is if you delay the diagnosis, there is a sequential increase in the mortality. And you need increased expertise to deal with these organisms when they show a lot of resistance, which I'm sure most of you see nowadays. The type of cultures we get is carbapenem resistant enterobacteria or PDR or MDR or XDR sort of an organism. So we need more expertise in trying to choose the right drug in the right dose and for the right duration for these organs. So these are the challenges when you have to deal with when you're dealing with these infections. And since I'm talking this to African doctors, so if you see the resistance patterns in Africa also is as bad as it is in India. So the NDR prevalence, as you see in Nigeria, is 89%. Uganda, you can see it is 20 to 50%. And the crab prevalence, which we'll talk about, is 55%. Kenya, also you have resistance. So basically, the resistance patterns is pretty similar, and they are prevailing in a big way in most of these African countries, is what we can make out. And Klebsiella pneumonia, more than 10% of carbapenem resistant Klebs pneumonia has been seen in African continent. So this is a nice sort of a picture for people. This is a nice sort of a representation as to what are the key drivers of antimicrobial resistance. If you see, the extreme right is the ones which are commonly prevailing drivers of antimicrobial resistance. The middle one is the moderate drivers of antimicrobial resistance, and the left one is the low drivers of antimicrobial. So it's a good one. So the main driver of antimicrobial resistance globally is only two: overusage of antibiotics in a patient and overusage of antibiotics in livestock, because there is increased usage of scheduled drugs in poultry farms and in the sheep farms, so on and so forth, because there is use of cholesterol in these sort of industry, and there is overusage of antibiotics. So these are some things that that seems to be problematic. And the moderate drivers of resistance is in-hospital spread of infections. So within the hospital, spread of infections or breach in the infection control practices in the hospital is the moderate driver. So for intensivists, please bear in mind overusage of antibiotics in the ICU, in the patients, and in the livestock, and in-hospital transmission with the breach in the infection control measures are the key drivers of antimicrobial resistance. And lack of vaccination and suboptimal dosing are also come under little moderate category of drivers. And the low drivers are where there are no rapid diagnostics that may not be available, and people traveling from one place, that also leads to global spread. So these are the key drivers for antimicrobial resistance prevailing in the world, which you all have to bear in mind. And this is a good figure for all our trainees. So when you look at the available antibiotic classes and the key mechanism of action, so when they ask in exam, put this figure. So there are drugs only acting on these elements within the cell. So as you see, this is the cell wall. The brown one is cell wall. The blue one is cell membrane. Then every cell has DNA, RNA, proteins, and hydrofolate. So when you look at antibiotics which act by inhibiting the cell wall synthesis. What are the antibiotics? I think the way to remember for all our intensivists is remember BCG vaccine, beta-lactams, carbapenems, cephalosporins, and glycopeptides. They act on inhibiting the cell wall synthesis. And quinolones act by inhibiting DNA synthesis. Okay, so that is something you can remember in this schematic diagram. And actinomycin acts by inhibiting RNA synthesis. But we have more drugs that act by inhibiting protein synthesis, and they are macrolides. So this also you can remember as annual maintenance, AMC, aminoglycosides, macrolides, chloramphenicol, and tetracyclines. So remember as the acronym AMC, so they act by inhibiting protein synthesis, and sulfonamides act by inhibiting tetrahydrofolate or folate, sort of a inhibition of folate. Sulfonamides act, and polymyxin acts by inhibiting cell membrane and disrupting the cell membrane. So this is a beautiful representation as to the key classes of antibiotics that we use in ICU, which act on different parts of the cell to inhibit the organisms or to kill the organisms. So now the question is, for antibiotic resistance, is there light at the end of the tunnel? Probably yes. So when you look at in vitro activity of antibiotics against carbapenem-resistant gram-negative bacteria at approved indications. So these are all the classes of resistance. You have CRAB. CRAB is carbapenem-resistant Acinetobacter. ESBL is extended spectrum beta-lactamase, and this is carbapenem-resistant Pseudomonas and carbapenem-resistant Enterobacteriaceae, so on and so forth. So all this, if you see, you have to look at the rows where there is more greens. So the antibiotics which are effective against all these classes, you have very few. So you have ceftriaxone, which is unavailable in India as of now. And if you look at polymyxin, they pretty much have effectiveness against all these resistant classes of antibiotics. So this is something that which becomes possibly a drug to be considered when you are dealing with extensive resistance in all these organisms. Because ceftazidime avibactam, which is very popularly used for carbapenem resistance, this does not have effectiveness against Acinetobacter, carbapenem-resistant Acinetobacter, and even it does not have effectiveness against NDM and metallobeta-lactamase. So that's why we need to combine ceftazidime avibactam with astronate. So there are limitations, but currently the antibiotic which possibly will cover all of this may be colistin bar polymyxins, and ceftriaxone unavailable. It may come to India anytime, and that is also having some effectiveness. So now we'll talk more on polymyxin. What is polymyxin? It's an old drug which was discovered in 1947, very similar to colistin. The only difference between colistin and polymyxin is in colistin you have this DLEU, which is replaced by DPHU in the molecular structure. So that is the only sort of a differentiator between colistin and polymyxin-B. How does polymyxin act? I told you polymyxin acts by inhibiting the cell membrane. How does it do? It causes first neutralization of the lipopolysaccharide, then it binds to lipopolysaccharide, which are all constituents of the cell membrane, and then it causes binding to the cytoplasmic membrane and causes, you can see this difference. What it has done is binds to cytoplasmic program and disrupts the cell membrane. You can see there is a disruption here, Michel formation, then there is leakage of calcium and magnesium, and the cell dies because the cell undergoes lysis because of cell membrane disruption or inhibition of the cell membrane synthesis by binding to lipopolysaccharides, and then there is a leakage and cell death that tends to happen. So this is the mechanism of action of polymyxin-B. So what is the spectrum of activity of polymyxin? It acts against E. coli, it acts against Klebsiella, this is how E. coli looks, this is how Klebsiella looks, it acts against Enterobacter, it acts against Pseudomonas, then this is the Acinetobacter, this is how it looks, it acts against Acinetobacter. But it does not act against this. It does not act against gram-positive. It does not act against anaerobes. And it does not act against Proteus, Providentia, Serratia, so on and so forth. So this is the spectrum of activity of polymyxin. And polymyxin has favorable pharmacokinetics. So the serum concentrations have been found to be consistent. Half-life is 6 hours. And there is patient-to-patient variability of concentrations is low in polymyxin. And clearance is non-renal. Because colistin causes nephrotoxicity, the argument is polymyxin is non-nephrotoxic, or at least nephrotoxicity is much lesser. And if you look at the MIC's breakpoint for polymyxin according to the latest UCAS, so for Pseudomonas, If you have to say it is sensitive, it has to be less than 2. Acinetobacter, it has to be less than 2. If it is more than 8, it is called resistant. So these are the CLSI and UCAST sort of a breakpoints that have been given for polymyxin to ascertain whether these bugs are sensitive or resistant to polymyxin. And so we need to see whether this all translates into whether it is clinically effective. And let us look into in vitro data, which is out of the patient, how effective it is. And then we look into clinical data. When you look at this in vitro data, so they have shown that at 2 milligrams per deciliter or 2 grams per ml MIC, 99.8% Pseudomonas was effective. Polymyxin was effective against it. 97.9% for Acinetobacter it was effective. For Klebsiella also it was effective. So basically it had a very good effectiveness at the MIC breakpoint that it was given. This was shown by a study that came from India itself. And polymyxin has a very good, so this was a study from Greece where they have shown it has a very good synergism, because polymyxin very often has to be given in combination with other antibiotics, and they found the best synergism was found to be with carbapenems. If you see, it has a good synergism with imipenem at 100% and with meropenem, and all carbapenems, if you see, there is a good synergism. And polymyxin-B alone, bactericidal action was around 87. This was in XTR Acinetobacter. So with tigecycline it was 87. So it's not a great combination. So combination of carbapenem and polymyxin-B against Acinetobacter had the highest synergistic effect. So for Acinetobacter, at least the in vitro data shows that it has a good synergism with carbapenems. So that is about in vitro. How about clinical efficacy? So there are a lot of small studies. So this was a study, retrospective study done to see its effectiveness against patients with Pseudomonas and Acinetobacter in 45 patients, where they give polymyxin 15,000 to 25,000. So if you give 15,000 for a 60 kgs, it comes to around 5 lakhs twice a day. If you give 25,000 units per kg for 60 kgs, it comes around 7.5 lakhs twice a day for a patient. So they showed that 8 days of IV polymyxin showed a good survival of 82 to 87% in this retrospective study of patients with sepsis due to Pseudomonas or Acinetobacter. And it had a good sort of a clinical cure rates is what was shown. So this was another study that came from US, retrospective study for respiratory tract infections in 25 critically ill patients, where they gave a prolonged sort of a course of polymyxin, where they had a causative organism of Acinetobacter, Pseudomonas infections. They gave so in this particular retrospective study, the clinical cure rate was 76% and bacteriological cure rate was around 41%. So this also showed it had a good sort of a cure rate or a clinical efficacy in this particular study. So the dosage that is advocated is 15,000 to 25,000 per unit in 2 divided doses if it is IV. And in ICU, we'll only talk about IV. As I said, for 60 kgs, if you calculate, which is an average sort of a weight, 60 or more than 60 to 70, it comes to around 5 lakhs BD. If you take 15,000 units per kg, if you take 25,000 units, it comes to around 7.5 lakhs twice a day for an adult patient. If it is IM, the dose has to be much higher, 25 to 30, which we seldom use it in our ICU. So when you are using polymyxin, it is important that renal function tests are closely monitored, and one should avoid using other neuromuscular block agents, and one should watch for any neuromuscular weakness, and one should watch for any nephrotoxicity like albuminuria, azotemia, cylindria, and neurotoxic effects, because most of these colistin or colistin-based combinations, they can cause certain neurotoxicity like dizziness, ataxia, drowsiness, and peripheral paresthesia. And drug reactions like urticaria, drug fever can happen with any drug. So these are some of the side effects that are reported with polymyxin. And this is again studies comparing which is better, polymyxin or colistin. So this was one study that came from Brazil, which showed if you see the nephrotoxicity, they compared between polymyxin and colistin. With polymyxin, the nephrotoxicity was 16.9% as opposed to colistin, which had 36.2%. And this was a study from US where that also showed polymyxin-B had a less nephrotoxicity as compared to colistin, which was 33 points. So which means nephrotoxicity also was found to be less. And polymyxin-B clearance in renal replacement also was pretty it was as good as in a normal patient. So the clearance lied within the range of irrespective of presence or absence of RRT. It means if there was RRT, the clearance was as effective as it would be in a normal patient. So the clearance uh, was equivalent. If you see these triangle ones are the clearance in RRT and these round ones are the clearance in a normal patient. So when you look, so now what does the guidelines tell us with regard to use of polymyxin? So these are guidelines which have come from various organizations like European Society of Clinical Microbiology and Infectious Disease Society of America, so on and so forth. So the guidelines suggest if you are dealing with carbapenem resistant enterobacteria, so one has to use combination of polymyxin-B along with antibiotics which have lowest MICs if feasible, or antibiotics which show susceptibility, MIC susceptibility to certain antibiotics. That antibiotic has to be taken and combined with polymyxin-B. But if there is no susceptible MIC then you have to take the MIC, the lowest MIC that you find, and then you should combine with second or third non-susceptible antibiotic. So, but what it means is recommendations say if you are dealing with carbapenem resistant enterobacteria, combination has to be given irrespective of any other drug. If it is susceptible, that is the best one. If it is not susceptible, you have to take the least sort of the MIC, the lowest MIC, second or third non-susceptible antibiotic. Most often it will be carbapenem that has to be taken. So if it is CRAB, carbapenem resistant Acinetobacter, again the recommendations say polymyxin-B has to be combined with antibiotics which have susceptible MIC. If antibiotics have no susceptible MIC, then polymyxin-B monotherapy has been suggested by these guidelines. But one can argue even in CRAB, I think the clinical practice is to combine with another drug. But if you look at the core recommendation, they suggest monotherapy is good enough for CRAB. But if it is CRE like Klebsiella pneumonia, Pseudomonas, and all the ESKAPE organisms, then combinations with second or third non-susceptible antibiotic has to be given, and most often it will be carbapenem. So summing up, antimicrobial resistance globally is emerging, and it appears more problematic in emerging countries, which is the worst. So which is worry for countries like us. And ESKAPE organisms, which is Enterococcus, Staphylococcus, Klebsiella, Acinetobacter, Pseudomonas, Enterobacteria, and E. coli are the most notorious. And we saw the challenges that we had to face when we are dealing with these organisms. And these organisms are more sort of they have more sort of an ability to develop resistance very quickly. So they're better at developing resistance. And polymyxin-B has re-emerged as a treatment for carbapenem-resistant gram-negative bacilli. And polymyxin-B has superior pharmacokinetic, pharmacodynamic, and safety profile. So the guidelines suggest polymyxin-B-based therapy for carbapenem-resistant enterobacteria, carbapenem-resistant Acinetobacter, and carbapenem-resistant Pseudomonas aeruginosa. And early empiric polymyxin-B or combination therapies have shown to reduce mortality and also morbidity in a given patient. So that's about it, folks. So I request you all to submit your valuable work to Journal of Acute Care. So you can visit my website to read to this lecture. So thank you. Thank you, Vinod.